Hey everybody, welcome back to the channel. This is student Dr. T with One Page Medical. Again, I'm a fourth year medical student. I'm making some educational videos mainly for myself to review content before I, get the gauntlet that is intern year. Today's video, we're going to be talking about the internal structures of the cardiac anatomy. So we're going to be talking about valves, we're going to be talking about internal structures, we're going to be talking about stuff in the right atria, left ventricle, right ventricle, and kind of how the blood flows through everything. And then at the end of the video, we'll take an extra little bit of time to talk about the cardiac conduction system from an anatomical standpoint. So the SA node, the AV node, the bundle of His, Purkinje fibers, all that stuff. So if that's something that you're looking for, go ahead and check out my video and we'll see you afterwards. Okay, so let's get into this video talking about the internal cardiac anatomy and kind of the important structures that you need to know. Again, we're going to follow the blood because I'm dumb and I want to think about things the easiest way possible, and I want to think about them the same way, right? So if I have a complex system, I want to dumb it down and then be able to think about it in the same steps every time. So we're going to follow the blood again. So the blood's coming from the venous system, deoxygenated. It's going into the superior vena cava and the inferior vena cava. It's dumping into this right atrium. Now the right atrium has two important structures in it. It has this blue circle right here, and what that is where the coronary sinus dumps all of the deoxygenated blood from the cardiac myocytes, right? So all of the cardiac vasculature collects into the coronary sinus and then empties into the right atria. This other oval structure right here is something called the fossa ovale. Now the fossa ovale is a remnant of a different structure called the foramen ovale. The foramen ovale is part of the fetal circulation, and what the foramen ovale does is it creates a atrial septal defect, so an ASD. So it allows blood to shunt across between the left atria and the right atria. And that's important for fetal circulation, right? And we'll have a whole video on fetal circulation in a little bit. But after the baby's born and after you get older, that fuses together, and then that forms part of the wall between the right atria and the left atria. The reason it's important to know about that is because sometimes that doesn't fuse, and you can have what's called the PFO, or patent foramen ovale. And that is important because if you have a patent foramen ovale, it can really increase the risks of having a stroke. Because if a clot dislodges from somewhere in your vasculature, it can flow into the superior vena cava, and then instead of just getting pushed out into the lungs and causing a pulmonary embolism, it can go across and then out into the arterial supply and then up into the brain. So, important structure to know about. You may get questions on things like PFOs or structures of that nature. Now, following the blood, we're going to go from the right atrium to the right ventricle, and to get there, the blood has to pass through the tricuspid valve. Now, the tricuspid valve is pretty easy to remember because it has three leaflets, so tri, or cusps, three cusps, tricuspid, and that is the barrier between the right atrium and the left atrium. Now, to remember what comes first, the tricuspid valve or the mitral valve, there's the little mnemonic, try before you buy. So that's how you know the blood's going to pass through the tricuspid valve first. Now, the tricuspid valve opens during diastole, so when the heart relaxes, it opens and allows filling of this right ventricle. And you can see that this I've drawn pretty poorly, but those kind of fibers connecting to each cusp are the chordae tendineae. And the chordae tendineae attach to these three structures right here, which are the papillary muscles. And the papillary muscles correspond to their leaflet, right? So you have your anterior papillary muscle and anterior leaflet, posterior papillary muscle, posterior leaflet, and your median papillary muscle and the median leaflet, okay? So blood fills up in here. We're going to have a systolic contraction of the heart. That's going to close this tricuspid valve, and it's going to open this pulmonary valve, right? So during systole from the right ventricle, blood flows out this pulmonic outflow tract through this pulmonary valve, right? And then into the pulmonary circulation. Now, the reason that this is important is because you can have things like HOCM or pulmonary hypertension or things that kind of can cause a blockage or stenosis of this pulmonary exit way. And just knowing how the blood is flowing and what is there, it's going to help you understand those conditions better. All right, so the blood enters the pulmonary artery or arteries, and it's going to go into the right and the left, get oxygenated, and then it's going to return to the pulmonary veins. Okay, so pulmonary arteries, pulmonary veins. Pulmonary veins now have oxygenated blood from the lungs, and it's going to dump into this left atria. So the left atria has one kind of structure that it's not shown very well on this, but it's important to know that it exists and that it's in the left atria. And I kind of just drew a little circle here to approximate where that might be, but it's the left atrial appendage. So if you imagine like this is the top of the left atria, it's like a little bleb that kind of comes off on the bottom. And it's just a little place where blood can pool and stagnate. And the reason that that's bad is because when you have stagnant blood, it clots and it can form, that clot can dislodge, and then that can become an emboli, and that emboli becomes a thrombus, okay? The most common people that you see that in are people with undiagnosed atrial fibrillation. So with atrial fibrillation, the heart is kind of already pumping kind of funky, so the blood flow isn't as clean, isn't as smooth, so you're more at risk for blood pooling in that left atrial appendage, and that's one of the reasons that people that have chronic atrial fibrillation are prescribed blood thinners to make sure that that doesn't happen. Another way you might get tested on the left atrial appendage is if a person has new onset AFib and you want to cardiovert them. So if you're going to cardiovert somebody, you need to look at the left atrial appendage before you cardiovert them. Because if you do, and there is a thrombus in there that you didn't know about, it can dislodge and you can stroke that patient out. And to look at that, you're going to do a transthoracic echocardiogram. Okay, so blood's in the left atrium. Now it's going to flow down into the left ventricle, and it's going to pass through the mitral valve. Now the mitral valve only has 2 leaflets. And again, the mitral valve opens during diastole, so it opens when the heart relaxes, and it closes during systole, right? So the blood can get ejected out into the aorta. Again, it has the similar structures as the right ventricle, right? You have the chordae tendineae, you have your papillary muscles, and the important one to know about is the posterior papillary muscle. Again, you have the anterior and posterior leaflet because there's only 2 cusps on this one. And the important one that they like to ask you a lot about is the posterior papillary muscle, okay? The reason that that's important is because the posterior papillary muscle only has one blood supply, and that one blood supply is the right coronary artery. These other papillary muscles have blood supply from, the right and the left, and if, the right or the left coronary artery becomes occluded, they're still going to be able to be perfused. But if the right coronary artery is occluded, then this posterior papillary muscle isn't going to be getting any blood flow. So you can cause ischemic damage to that much easier than these other 4, right? And that puts it at much higher risk of rupture. If the patient has a right-sided MI. And again, we'll go over kind of ACS and things to look for in that. But if that does rupture, what that's going to do is it's going to cause acute mitral regurgitation, right? And it's going to just basically cause rapid onset heart failure because this valve isn't going to be able to close anymore. And you're just going to have blood pushing back into the vasculature and then backing up the entire system. So that's the left ventricle. We're going to contract the left ventricle. We're going to push that blood out through here, and then right kind of behind this pulmonary artery, you have a circular valve with kind of 3 cusps on it, 3 leaves on it, and that's going to be the aortic valve. And then the aortic valve leads to the aortic outflow tract. Now, the aortic valve is important because The difference in pressure that is seen between the left ventricle and the aorta during diastole is what's called the coronary perfusion pressure. And that is what is responsible for perfusing the heart, right? So if you have something like aortic stenosis, right, where you're not getting all of this blood out and you're having a low aortic pressure and a higher ventricular pressure, that means the difference between those two things are going to be smaller in diastole, which means you're going to have a decreased coronary perfusion pressure, which means it's going to be harder to perfuse the heart. So that's why in questions you'll see they'll give you a really advanced case of aortic stenosis and they're having anginal chest pain, right? They're having that ischemic chest pain because that aortic stenosis is so much that the aortic outflow tract and the left ventricular pressures are equalizing or getting closer to equal, so you're not having that adequate coronary perfusion pressure. And that also translates to decreased systemic blood pressures, and it can cause, lightheadedness, dizziness, you're not perfusing the brain well, all that kind of stuff. So then we have, the blood, it comes out into the aorta and down into the rest of the body. And, those are the real important structures that you need to know when you're thinking about the internal structures of the heart, and knowing how they work and where the blood supply is and where they're at can help you understand a lot of these pathologies that happen here, right? Now, the one other thing I want to talk about is the cardiac electric system of the heart from an anatomy standpoint, right? And it kind of looks like this right here, right? And if you can imagine just like superimposing that on the heart, you can see that this would be the right atria, this is the left, this is the right ventricle, this is the left ventricle. Okay, so we'll start with the SA node, right? And this is a kind of a depiction of what's called cardiac pacemaker cells. So the heart has two types of cells, pacemaker cells and myocardiocytes. The pacemaker cells are responsible for generating and transmitting the electrical signal that causes the heart to contract. The cardiac myocytes then sense that signal, and they are the ones that actually do the contraction. And that's what's called excitation-contraction coupling. And part of the reason that works is the structure and function of this system. So you have your SA node right here, and this is the intrinsic pacemaker of the heart, right? So this is where most of the automaticity happens in those pacemaker cells, right? And they kind of fire at a set rate. And that set rate typically is between 60 and 100 beats per minute, right? So SA node fires, it comes down the track, and it comes to the AV node. Now, there also is some accessory tracks here, and that comes into play when you're talking about different arrhythmias like AV-NRT and things like that, but we'll have a separate video talking about arrhythmias and get into that. But know that there are accessory tracks. So then that comes to the AV node, right? Now, the AV node's job is actually to slow conduction, right? Because the AV node really separates the electrical signal from the atria and the ventricles, right? And the atria are much smaller and they can contract much easier, much quicker, but you have a lot more ground to cover in the ventricles, right? So that excitation contraction coupling is going to take longer for it to contract and then reset out of that refractory period and be able to contract again with another signal. So the AV node slows it down enough to basically allow those cardiac myocytes to reset and then be able to get the next signal, right? So actually the slowest conduction pathway in the heart is the AV node. And it has an intrinsic set rate of about 40 to 60 beats per minute. Just a fact, memorize it. You might get tested on it. And same with these other intrinsic rates that I'll give you. Next, it comes down to the bundle of His, right? And that kind of shoots down, and then you have the right and left bundle branch, right? And if you've ever heard of a bundle branch block, that's where this is happening, right? And then the left and right bundle branches flow off into the Purkinje fiber system. And this Purkinje fiber system is actually where the fastest conduction happens. So slowest is the AV node, fastest is the Purkinje fiber system. And we'll have a whole video on kind of cardiac electrophysiology. It's a little bit too complicated to get into in this video, but hopefully this quick overview gave you guys something useful, and we'll talk about more in the next video. All right, guys, thanks for stopping by. Hopefully you got something out of that video. If you did, feel free to share it amongst your friends. Feel free to like, subscribe, all that stuff. Again, I'm really just doing this for me. It's a good way to review and a good way to solidify, my education. But if you found it valuable, feel free to, let others know about it. If you have any suggestions or I got anything wrong, please let me know in the comment section. I'll try to update the video or put in some notes to let people know what I got wrong. And also if you have any suggestions about, ways to make the videos better. This is my second video, so I'm really, really new at this. Don't really know what I'm doing, trying to figure it out. So also open to suggestions about that stuff. So thanks for coming by. I hope you got something out of it, and we'll see you next time.